Welcome. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology, and this is another installment of Rheumatology Virtual Grand Rounds. I'm very, very pleased to have my good friend and colleague, Jack Cush, to discuss with us initiating biologic therapies and strategies to reduce the risk of complications. We live in this garden of earthly delights in terms of all these drugs that we have available to us to treat patients with autoimmune and autoinflammatory disease. They're all highly effective. I think most of us, and evidence suggests, that we make our decisions with our patients based upon safety first, as it should be. Safety is a big topic. It's very complicated. It involves infections, cancers, allergic reactions, etc. I don't know anyone who has thought about this better than Jack Cush. So welcome, Jack.
Hello, my name is John Cush. I'm from the Baylor Research Institute in Dallas, Texas. Today we're going to talk about initiating biologic therapies and what strategies can be implemented to reduce the risk of complications. You can see from this list that there are 9 currently FDA-approved biologic therapies for use in rheumatoid arthritis. Certainly these agents are used in other inflammatory diseases and have been shown to be highly efficacious, especially in patients who previously not responded to conventional therapy. But with new therapy comes new risks, and concerns about safety has driven a lot of research in this area, and I think a lot is now known about how we can best manage our patients with these agents, yet avoid some of the major safety concerns that are sometimes associated with them. It's important to know the key questions when embarking upon biologic therapy. It's first the most important to know what the actual indication for biologic use is, meaning that it should be used for one of its approved indications. When one strays to unapproved or unofficial uses, you're often going into an area where very little is known about the safety of the medicine. Second, it's important to define realistic benefits and realistic risks for the individual patient under consideration. What is the likelihood the patient is going to benefit from this therapy? What's the potential magnitude of benefit that one might realize with such therapy? It's also important to note whether this particular patient has heightened safety risks because of their background, comorbidities, or therapies. Next, it's important to know what can be done to minimize these risks. Some of these can be under the direction of the physician and the prescriber. Some of these need to be accomplished by the patient with guidance from the prescriber on how to achieve such outcomes. And lastly, it's important to know what the expectations are as far as therapy, meaning how am I going to define my anticipated benefit, what's the time frame, what measures am I going to employ in assessing whether, in fact, the patient meets the expected improvement in disease. So it's important to know and to have a perspective on the likely and unlikely risks associated with medicine use. In this slide, I show you 3 boxes starting in the upper left, the most common things that are generally seen with all the biologic therapies. And foremost amongst these is either injection site reactions or infusion reactions, generally termed under the heading of administration reactions. These are quite common. They're quite minor. They're usually a nuisance and usually can be dealt with successfully without cessation or interruption in therapy. Next are non-serious infections. These are probably the most common adverse events seen in all the clinical trials with many thousands of patients. It's important to note that in those clinical trials, patients were not stopped from taking their biologic, nor was their biologic therapy suspended or held for patients who had a cold, URI, bronchitis, on an antibiotic for something like bronchitis and whatnot. Of course, it's okay to hold and wait for those events to pass, but there really is no reason to do so from a safety standpoint, meaning those do not escalate to worse events if they were to be continued, if the biologic were to be continued. Those are most common things. Those are things patients need to know about. The uncommon things are what people worry about: risk of serious infections, skin reactions, hypotension, herpes zoster, latent tuberculosis being discovered during screening or during treatment, hepatotoxicity, and pregnancy. These are things that come up. These are all very uncommon events. Generally, much less than 5% of the population will get these. It's important to know which of these you can control, and avoid through proper screening and education. Often the things that really bother the patient or get in the way of biologic use with the prescribers are the very rare events. Again, these include things like opportunistic infections and even TB, lymphoma, and other forms of cancer, autoimmune features such as drug-induced lupus, demyelinating diseases like multiple sclerosis, optic neuritis, progressive multifocal leukoencephalopathy, or PML, hepatosplenic T-cell lymphomas, hepatic failure, and even death. These are all very rare events in patients receiving biologics, but this does show this is a great concern for a lot of people, and it is usually the tail that's wagging the dog on prescription here, meaning that people are afraid of these things and they won't use them because of it. But it has to be in perspective. These are 1 in 1,000 events. The uncommon things are, again, less than 5%. The common things can be 30, 40% of the population. So, again, it's important to keep these in perspective with patients when using these agents. Let's have a case here. Mrs. Bristol is an uncontrolled, active polyarticular RA patient, but she's going to start on a biologic, but she's concerned about the risk of infection. She hears about it all the time on TV. She wants to know what can be done to minimize the risk of infection. And here are your options. Number 1, check her immunoglobulin levels. Number 2, reduce the dose of methotrexate. Number 3, reduce her dose of prednisone. Number 4, take a daily multivitamin. Well, the obvious answer here, in my mind, is reduce the dose of prednisone. Prednisone has clearly been associated with infectious risk, more so than any other drug. Immunoglobulin levels may be low in some patients with rheumatoid arthritis, but they have a very low predictive value as far as future infectious risk. Now, if someone's had recurrent infections in the past, it may be prudent to check their immunoglobulin levels to make sure that they don't have common variable immunodeficiency or other forms of immunodeficiency or immunosuppression. Reducing methotrexate dose will only worsen the disease and doesn't contribute to infectious risk. And multivitamins are part of good health care, not part of an infectious risk program, risk reduction program. So there are certain things a physician can do to minimize risk. Number 1, educate the patient. Let them know the expected benefits are, what kind of adverse events they might experience, and what the rules are for discontinuing the medicine on their own or for calling you for further guidance. Knowing who to give the drug to is very, very important. So careful patient selection. There may be situations when it's important to not use a biologic agent. So you should refrain using biologics or rethink it when the anticipated benefit is very small or hard to define, and the risks seem to be greater than usual. Again, if no good is going to come from the use of biologic, do not use the biologic. It's important to minimize risk through screening, prevention, and monitoring, and we'll talk about these in subsequent slides. There are patient measures to minimize risk. Compliance with visits, with medications, with laboratory testing, these are all gigantically important in minimizing risk. Weight control. Amazingly, patients who actually are obese are less likely to respond to therapy, and hence a better response may actually lend to better safety in the long run. So weight reduction, not that we know that being overweight causes more toxicity in general, but it seems to be a good plan going forward. Certainly smoking cessation. Smoking will increase one's risk of pneumonia and other infections, and certainly worsen rheumatoid arthritis. So dental care, smoking cessation, and weight control are all factors that have been implicated in both the risk of rheumatoid arthritis, but also the severity of rheumatoid arthritis. So control of these features may be important in minimizing risk. And then having the patients receive appropriate vaccinations is an important measure as well. So when looking at the risk of infection with especially a condition like rheumatoid arthritis, we do know several facts. Number 1, the best predictor of a serious infectious event is 1, the severity of rheumatoid arthritis itself, and that includes inflammatory load and debility. Number 2, steroids. Almost in any dose, steroids show a dose-related increase in serious infectious and even non-serious infectious events. Third, comorbidities. We all know about heart failure, renal failure, diabetes, but chronic lung disease, either interstitial lung disease, COPD, and other forms of chronic lung disease are very, very prevalent in our patients and may contribute to significant infectious risk. Breakdown of skin, your number 1 barrier against infection. If that breaks down, that will increase one's risk. Ulcers, open wounds, and joint surgery. It's clear that DMARDs do not, in of themselves, increase risk. So things like that we commonly use, methotrexate, gold, leflunomide, these sulfasalazine, hydroxychloroquine, these are not agents that cause risk. It is clear from the research that biologics yield a small but significant risk that needs to be considered. In general, if you look at the package insert on all these drugs, there is almost a twofold increase, from 1% to 2%, looking at placebo-treated patients and those on active biologics. So there is a small increase, but it's generally not of a major significance, but in some patients it might be significant. The next slide looks at the risk of serious infection based on disease activity. And this is a study from a British cohort, which shows that it doesn't matter whether you're on a DMARD or whether you're on etanercept in red, that actual infectious risk, or in this case, rate of infections per 1,000 patient years, goes up based on disease activity as measured in DAS score. So it's disease activity, not the medication, that determines the risk of infection. In this community-acquired pneumonia population study, they look at elderly people in the community and follow them for a 3-year period. You can see that the elderly have a rate of community-acquired pneumonia of 14 per 1,000 patient years. If the subset of people who are immunocompromised are looked at, you can see there's almost a 3-fold risk. If you look at chronic lung disease patients in that group, there's almost a 4-fold risk, and the same can be said for steroids. This is just like the data that's underneath, on the bottom half of the slide, from Fred Wolf's National Data Bank of almost 17,000 patients, where his rate of community-acquired pneumonia was 17 per 1,000 patient years. And the things that increased this rate up as high as 2 to 4-fold was higher age, prednisone use, diabetes, myocardial infarction, and chronic lung disease. So again, in this case as well, infectious risk is driven by age, severity, steroids, and comorbidity. Hence, these are the things you want to control. You can't control age, but you can control severity and steroids and better manage comorbidity. Here, looking at 3 large databases of Pennsylvania Medicare population, the National Data Bank, and Tennessee Medicare populations, you see that TNF inhibitors have a low risk or hazard ratio of serious infectious events. Prednisone has a higher risk, but even high-dose prednisone has an even higher risk. And lastly, this is a study from the German Biologics Registry, and it answers the question, if I have someone and I put them on a steroid or I put them on a TNF inhibitor, are there additive effects here? Look at the far left of this graph. When you're looking at just DMARD and TNF inhibitor-treated patients, the risks seem to be very low, especially when you're on 7.5 milligrams of prednisone or less. That's the first 2 rows that we're looking at, first 2 columns that we're looking at. The next columns, the next 2 pair, is when steroid doses between 7.5 and 15. You can see the rates of infection go up a little higher. But it seems to be the highest when patients are on steroids of 15 milligrams or higher, in the last 2 on the right. And then we look at the columns going back behind the front column, and that's the number of risk factors the individual has. So if the person in the front row has no risk factors, the ones in the back rows have 3 risk factors, and these risk factors include age, lung disease, renal disease, number of failed prior treatments, and prior infectious events. So you can see that the more risk factors you have, the higher the risk. The more you're on steroids, the higher the risk. And in those people, the addition of a TNF inhibitor or a biologic may augment the risk in general. But again, it's also, you really see this in a high-risk individual. So overall, in looking at infectious risk, it is augmented by the severity of RA and inflammation, by steroid use, by comorbidities, and higher doses of TNF inhibitors in data I did not show. Elderly at higher risk and prior history of SIEs. I mean, if you had pneumonia in the past, you're more likely to get it in the future. So the 2 on the bottom you can't control, but the 4 above it you can control as a means of reducing risk. Let's go on and look at Mrs. Bristol again. Now Mrs. Bristol is going to receive a biologic therapy that requires TB screening. She was born in South America and has a history of prior BCG vaccination. She says her past PPD tests done at her work were positive, and that she was told that she's not supposed to have them repeated again. She's never been treated for TB. What are you going to tell this patient? 1, that all patients must receive TB testing with a PPD test. 2, all take a history of symptoms to know whether or not we can proceed or not. 3, she needs to undergo 2-step tuberculous skin testing. 4, quantiferon or an IGRA would be preferred in her. Or 5, chest CT needs to be done first. The right answer here is the use of an IgRA or a quantiferon test to define whether or not she has had latent tuberculosis or PPD-related, BCG-related PPD positivity. The next slide looks at TB risk. We know the TB risk is augmented by host factors, where you're born, where you're living, if you're in crowded populations. Where you were born is very, very important, whether you've had recent exposure, and certain drugs, steroids, TNF inhibitors more so than other biologics. And on the far right, you can see what happens in different populations, Sweden being a non-endemic population and Korea being an endemic population as far as TB use. You can see that the normal population risk, which is about 3 or 4 per 100,000 patient years, the risk is 1. But if you have rheumatoid arthritis, the risk almost doubles, and that's in a rheumatoid who's not taking a TNF inhibitor. If you look at the blue line to the right of that, an RA patient on a TNF inhibitor has almost a 9-fold increase. So adding a TNF inhibitor does increase risk of TB, more so in this situation than with regular infections. Clearly, TB risk is important when you're using a TNF inhibitor and possibly other drugs. Now, if you look at an endemic population where TB is quite prevalent, like Korea, where the rates can be as high as 50 to 300 per 100,000 patient years, if the population rate is 1, an RA population has a 9-fold increase, even though they're not taking a TNF inhibitor. And then you put them on a TNF inhibitor, it goes up almost 30-fold. So where you're born is very important. Being on a TNF inhibitor also increases your risk. Who should undergo PPD testing? The package labeling says that all TNF inhibitors should be preceded by the use of either a tuberculin skin test or an IgRA test. Abatacept, tocilizumab, and leflunomide are also required to have tuberculin skin testing or PPD testing. Not required are methotrexate, anakinra, and rituximab. So should you do a tuberculin skin test, the traditional PPD test, or an IgRA, a gamma interferon releasing assay, to screen your patient? Well, here's a comparison of the two. You can see that they are both really quite effective as far as sensitivity and their predictive values. In general, the TST, the PPD test, is the preferred test in low-risk populations because it is cheap. It has been used for many years. There's a lot of experience with it. It has a sensitivity almost 100%, and it does have a lower specificity in general. The IgRA is more specific because it will not be positive in patients who had a prior history of BCG. The IgRA is preferred in patients who had a history of BCG vaccination, patients who are unreliable and not likely to come back in 72 hours to have their test read, and maybe even patients who had a recent infection. You can see the specificity is better. On the far right, you can see that not all patients with a positive TST will have a positive IgRA. In fact, the overlap between the two varies widely in many studies, from anywhere from 20 to 70% of patients actually being positive for both when one is positive. So again, it is very reasonable to do one or the other in most situations. In the American College of Rheumatology, I recently published an article with my coworkers Catherine Dow, Kevin Winthrop, and Richard Chasen on 10 guidelines for screening for TB. Number 1, everyone should be screened for latent tuberculosis infection prior to TNF inhibitor use with either a PPD or an IgRA. 2, when is an IgRA indicated? Certainly when it's available, but also when there's a history of BCG vaccination or when the patient may be unreliable. Third, the BCG vaccinated patients should also be tested for latent tuberculosis because, remember, they come from a place where TB is prevalent, which is why they receive BCG. Hence, if they are positive now, many years later, they're actually more likely to have active infection, latent infection, than to have BCG-related PPD positivity. Most of those cases lose their PPD positivity over time. Number 4, either PPD or IgRA positivity is evidence of infection and needs to be dealt with. 5, 2-step testing is only required in healthcare workers. 6, a chest X-ray is only useful in diagnosing active TB, not latent TB. 7, a PPD test should be repeated or done periodically. It's not clear whether that should be done annually. We tend to prefer to say it should be done when risk changes, meaning there's new exposures or your actual risk has changed. Then it should be repeated. 8, patients with a documented history of adequately treated latent tuberculosis infection or adequately treated active TB can safely go on to receive TNF inhibitors. 9, latent TB patients and the screening for that should be done before the use of a TNF inhibitor, and the package insert says preventative antituberculous therapy must be initiated in patients before you give the TNF inhibitor if they are found to have latent TB. Latent TB being defined as a positive PPD or positive IgRA with a negative chest X-ray and no signs and symptoms. And lastly, again, the guidelines do not call for screening in patients receiving DMARDs like methotrexate. So let's go back to Mrs. Bristol. We want to avoid these infections. We want her to receive her vaccine. She's on a biologic, and now she comes to you and says that she has to travel to the Caribbean on business, and she's required to have a battery of new vaccines, and she hands these to you. You tell her which of the following vaccines should she not receive. These are, number 1, DPT, diphtheria, pertussis, and tetanus. Number 2, hepatitis A. Number 3, IM typhoid. Number 4, the pneumococcal vaccine. Or number 5, the vaccine for herpes zoster. The right answer here is herpes zoster because herpes zoster is the only one on this list that is a live vaccine, and live vaccines cannot be given to patients receiving biologic therapies. So the CDC has said that when looking at shingles, it's a very common event. 1 out of 3 people will have shingles in their lifetime. Zostavax was a vaccine for shingles, was approved in 2006, shown to give a 50% reduction in actual zoster events and a 2/3 reduction in post-herpetic neuralgia. It is indicated in adults over the age of 60 per the CDC. It is okay to give the shingles vaccine or the Zostavax in patients who are receiving DMARD therapy or prednisone. So if you're on methotrexate, azathioprine, sulfasalazine, hydroxychloroquine, you can receive the Zoster vaccine. And same thing for prednisone, up to 20 milligrams a day. Again, it's not indicated for the acute treatment of Zoster, and it should not be used in patients who are receiving biologics, especially those who are on TNF inhibitors. If you should be receive this vaccine, you should be off of a biologic and then resume it at some point later. Their rules are give it 2 weeks before and 4 weeks after anticipated immunosuppression. So in vaccinating our patients, we should note, number 1, that RA patients have lower responses, humoral responses, than do controls, but that these humoral responses can be adequate when patients are vaccinated against influenza or pneumococcal vaccine when they are receiving prednisone, methotrexate, TNF inhibitors, abatacept, and even tofacitinib. There is a blunted response when someone has received rituximab, the B-cell monoclonal antibody, and even tocilizumab. Hence, if you're going to receive rituximab or tocilizumab, it's important to do all your vaccinations prior to the use of those antibody-based therapies. The PDR and all guidelines say do not vaccinate patients with live vaccines when they're receiving a biologic therapy. If you are going to use a live vaccine, it requires cessation of the biologic for 4 weeks, and then giving the vaccination, then waiting for at least 2 weeks and maybe 4 weeks after the vaccination before you can restart the biologic agent. There's a listing of inactive and live vaccines. On the left are the inactive vaccines. On the right are live vaccines. Note that influenza and pneumococcus are safe. All the hepatitis vaccines are safe. DPT is safe. There is a IM typhoid, which is safe. The oral typhoid is not safe because that's a live vaccine. So this is for your reference. Let's go back to Mrs. Bristol. She has uncontrolled polyarticular RA. We want to start her on a TNF inhibitor. What laboratory testing should we undergo? Number 1, a CBC, CMP, SED-rate, CRP, and ferritin. Number 2, a CBC, CMP, hepatitis C antibody, Hep B surface antigen, Hep B core antibody, Hep B surface antibody. Number 3, CBC, HIV, an IgRA, and an RPR. Number 4, CA125, rheumatoid factor, CCP, ANA, DNA, C3, and C4. The right answer here is 2, CBC, CMP, Hep C, Hep B testing. The rest all are hampered by having one that's inappropriate. In the first choice, the ferritin is not necessary in any way. Number 3, the HIV and RPR are not necessary. And number 4, the CA125 and the serologic testing for ANA and all serologies and complements makes no sense at all. It has very little to the safety and management of that patient. So next slide, we look at what's the likelihood of getting reactivation of hepatitis B if you have resolved infection. Resolved infection means that you are hepatitis B surface antigen negative, you have normal LFTs, but that you only have a core antibody that's positive. That may be with or without a surface antibody that's positive. Again, we do know from many studies that TNF inhibitor-treated patients are usually not adequately tested. Certainly, there are many cases of hepatitis B activation and reactivation when they are hepatitis B surface antigen positive, so you want to have caution there. However, there does not seem to be much risk if you have evidence of inactive hepatitis B, such as with a B surface antigen negative and core antibody positive. This is a compilation of many studies showing you almost a minuscule, less than 1% risk of reactivation if you were to use a TNF inhibitor in someone who had evidence of dormant Hep B infection. So it is safe to use that. You need to monitor patients for signs, symptoms, and LFTs. The predictive value of viral loads is really not that certain. What about if someone has hepatitis B surface antigen? The next slide shows you what happens. On the top panel, you have 18 out of 20 patients who are Hep B surface antigen positive, and on the far right, you can see that the majority, two-thirds of them, had evidence of hepatitis B reactivation because these people did not receive any viral prophylaxis. On the bottom row, you see this a smaller subset of patients, 6 out of 6, who are B surface antigen positive, but they did receive lamivudine prophylaxis, and none of them, with up to 2 years of follow-up, had reactivation. The point being that you don't want to use a biologic in someone with hepatitis B surface antigen, but if you must, you have to give viral prophylaxis. So the strategy is screen all high-risk patients. That includes patients receiving biologics. Screen all patients going on immunosuppressants for hepatitis C and hepatitis B infection. Now it should include a surface antigen and a core antibody, and if appropriate, follow up with viral loads for hepatitis B. You should avoid biologics in those who are B surface antigen positive. You should refer to a hepatologist for preemptive antiviral therapy if such patients need to be treated. Patients with resolved infection may receive biologics with caution, and again, caution in those with the most intense forms of immunosuppression who are core antibody positive. Lastly, there are some guidelines as to who should not receive TNF inhibitors, and we just discussed this. Patients with active hepatitis with B surface antigen positivity. Also, patients who have non-tuberculous mycobacterial infections and patients with invasive fungal infections, because despite treatment, you'd never fully eradicate those bugs. And lastly, patients who are receiving intravesicular BCG treatment for bladder cancer. Notice, if you will, there's an asterisk for the first three, and that means that if you absolutely must use the drugs, you could consider prophylaxis along with the biologic and careful observation. Next, Mrs. Bristol has a concern for cancer. She's going to go on a biologic. However, her son was recently diagnosed with Hodgkin's lymphoma. What are you going to tell her? Number one, taking a biologic definitely increases her risk of cancer. Number two, the risk of lymphoma is most influenced by uncontrolled inflammation. Number three, Hodgkin's lymphoma does not occur with TNF inhibitors. Or number four, she should see an oncologist for a second opinion regarding her cancer risk. The right answer here is two. The risk of lymphoma is most influenced by uncontrolled inflammation. The next slide shows that overall patients with rheumatoid arthritis have no risk of cancer or neoplasia, but that's a little bit misleading because it turns out that there are decreased rates of adenocarcinoma of the colon and breast cancer. There are increased rates of lung cancer, lymphoma, skin cancers, and overall this balances out to an SIR of 1 or relative risk of 1, but notice that there are some that are higher and lower. Interestingly, the risk of biologic-associated cancers is exactly the same risk as that assumed by RA, meaning it is the RA and uncontrolled inflammation that determines risk, not the use of the biologic in most cases. We do know that lymphoma risk, for instance, is augmented by long-standing disease and by the intensity of inflammation. It is more likely to be seen in elderly individuals, and there are some other therapies, especially chemotherapeutic drugs, that may increase the risk of lymphoma as well. In this study done in Sweden, you look at the risk of new cases of RA between 1997 and 2006. The vertical line is the onset of RA, and the horizontal lines indicate the cancer and lymphoma incidence prior to the onset of RA, showing the relative risk was at 1 or below 1. However, at the onset of RA, that the risk starts to go up, not for cancer, but for lymphoma, and only after 6 years of activity. So again, it is uncontrolled inflammation over time that it seems to augment the risk of lymphoma in RA. Overall, we can say a few things about reducing the risk of neoplasia. Number one, that you should encourage your patients to engage in careful annual health maintenance measures, as these will identify cancers at the earliest possible stage. Patients with skin cancer need to have annual skin examinations. On the bottom of the slide, you can see wording from the package insert on the TNF inhibitors, which says patients on chronic immunosuppressants or psoriatic patients with a history of PUVA treatment should be examined for the presence of non-melanoma skin cancers before and during treatment with a TNF inhibitor. For lymphoma, you need to be careful as far as patient selection, noting that the elderly are more at risk, the higher the inflammation load, and patients with a prior history of lymphoma. Breast cancer, self-exams, mammography, prior cancers, time oncologic evaluations, and screening measures as done by the oncologists are all going to be important. So if you're looking at the overall risk of biologic use and safety events, you can look at on the far left that there are a number of important safety events: pneumonia, tuberculosis, opportunistic infection, cancers, optic neuritis, hepatotoxicity, and you can identify patients at risk. You can utilize screening measures, and you can use preventative treatments and preventative measures as well to minimize the risk in patients going forward. Biologics have been used in over 4 million people worldwide. There's a great deal known about the risk of these agents with regard to serious infections, opportunistic infections, including TB, cancer, and lymphoma. We are no longer in the dark ages about the actual risk here. It's important that you suspect these events in patients who are going forward and that you monitor for them. It's important that you educate your patients about them so that they'll know when to come in and know when to stop their medicines. Screening, patient selection, and vaccination are important parts of this scheme to minimize risk, and maintaining optimal disease control and reducing steroid use are additive in this regard. I hope you found this informative. Thank you very much.
Thanks, Jack. That was really terrific. You know, I'd like to go over a few key points that I think are important. First of all, risk is not monolithic. Patients listen to the television commercials and they hear this litany of terrible things, but they have to understand that there are common, uncommon, and very rare adverse events, as Jack so nicely points out. And secondly, there are a series of things that we can do to minimize risk. We need to continuously understand the basic mechanism of action of these drugs so we can reach in the immunology toolbox and see what happens to animals that are deficient in cytokines or defective pathways. We need to understand what the type of infections that patients with primary immunodeficiency diseases who have defects in T cells or B cells or intracellular signaling get. This will make us more confident in understanding this. In addition, I like the way that Jack talks about the other risk factors. Rheumatoid arthritis activity is a risk factor, so we need to treat it, and that can be explained to patients. The other drugs besides biologics, in particular glucocorticoids, and then always the comorbid diseases. We need to screen our patients, we need to educate our patients, and we need good systems in place when problems arise. So please come back for other installments of our series, Rheumatology Virtual Grand Rounds. There are a number already up and more coming. Come to our website, Rheumatology Highlights Report. And most of all, we'd love to see you in Cleveland, May 2nd through 5th for Biologics 5, the best biologic summit in the world.